Welcome to Module F1, Understanding Diagnoses. I am so glad you're here. If you have recently been through an evaluation with your child, or you are about to be, or you've had a report sitting on your counter for 3 months and you still don't fully understand it, this module is for you. Over the next several lessons, we are going to go through everything you need to know on how to read your child's report, understand their diagnoses, and walk through your next appointment feeling like a partner rather than a bystander. Let's get started. This is how our session is going to go today. We're going to talk about speech versus language. What is the difference? Receptive language versus expressive language, pragmatics, common diagnoses, and understanding the evaluation report. This may sound pretty familiar to you. You left the evaluation with a report, a diagnosis, and 20 minutes to absorb it all. Here's what you actually needed to hear, calmly, clearly, with no jargon. I want to start by acknowledging something. The evaluation appointment is one of the most overwhelming experiences parents in this community go through. You're handed a thick report, walked through scores and percentiles and standard deviations, and then sent home to figure out exactly what any of it actually means for your child. This module exists to close that gap. By the time we are done, you're going to be able to read that report yourself. You are going to understand what the scores mean. You are going to know the right questions to ask. And you are going to feel a lot less alone with all of it. Let's start with the most fundamental thing, the difference between speech and language. Because I promise you, it is not the same thing. And knowing the difference changes how you read everything else. Before we can talk about diagnoses, we need to make sure that we are all speaking the same language. No pun intended. One of the most common sources of confusion for families entering the speech pathology world is that we use the words speech and language as though they mean the same thing. They do not. And the difference matters enormously for understanding your child's profile. Speech is the physical, mechanical act of producing sounds. It involves your lips, your tongue, your jaw, your breath support, and your vocal cords all working together in a very precise, coordinated way to produce the sounds of your language. When we talk about speech, we are talking about articulation, the accuracy of individual sounds, fluency, which is where stuttering lives, and voice, as in voice quality. Language, on the other hand, is a system of words and rules we use to communicate meaning. Language is not about how you produce sounds. Language is about what you understand, what you can express, the words you know, the grammar you use, and how you use communication socially. Language can happen through speaking, through signing, through writing, or through a communication device. The modality is separate from the language itself. Here is why that distinction matters for your child. A child can have perfectly clear speech and still have a significant language disorder. And a child can have a rich, complex language while having significant difficulty with the physical production of speech sounds. These are different systems. They have different causes, and they require different interventions. Within language, there is another distinction I want you to understand: receptive and expressive. Receptive language is what your child understands, the ability to process and comprehend what is said to them. Expressive language is what your child uses to communicate, their ability to use words, sentences, and grammar to express their thoughts, needs, and ideas. Many children with language delays have a gap between their receptive and expressive abilities. They understand significantly more than they can say. This is actually a positive sign in many cases. It tells us that the comprehension system is working, even when the expressive system is lagging. But it is important to know about because it affects how you interact with your child at home. If your child's receptive language is also significantly affected alongside expressive, that is a different clinical picture, and it is one of the strongest predictors of persistent language difficulty. We will talk about that more when we get to the diagnoses section. Pragmatics. There is a third area of language I want to introduce you to, pragmatics. Pragmatics is the social use of language, the ability to use communication appropriately in context, taking turns in conversation, staying on topic, reading social cues, understanding that what someone says is not always exactly what they mean, knowing how to start and end a conversation. Pragmatic difficulties are common in children on the autism spectrum, but they occur across many diagnostic profiles. And because pragmatic skills are so tied to social connection, parents often feel the impact of pragmatic difficulties in ways that are hard to name. Their child talks, but conversations feel one-sided, or their child says things at the wrong time, in the wrong way, or their child struggles to connect with peers even though they have words. I want you to hold these three distinctions: speech versus language, receptive versus expressive, and pragmatics. They are the vocabulary of everything that follows. Now let's talk about the specific diagnoses you are most likely to encounter. I want to walk through each one clearly: what it is, what it looks like in daily life, and just as importantly, what it does not mean. Because some of the most damaging information parents receive is not what they are told, but what they are left to assume. An expressive language disorder means a child has significant difficulty communicating their thoughts, needs, and ideas through language in a way that is below what we would expect for their age. Their vocabulary may be smaller than expected. Their sentences may be shorter or grammatically simpler. What it does not mean that your child is not intelligent. Expressive language and intelligence are separate systems. A receptive language disorder is often missed because children can become very skilled at using context, routine, and social cues to compensate for their difficulty processing spoken language. At home, this can look like not following multi-step directions, difficulty answering questions, needing instructions repeated frequently. And then last, we have a mixed receptive and expressive disorder. Just like the name says, it is both the understanding part of language and the expression. These are both affected. And this is the most significant predictor in persistent difficulties in life and into adulthood even. For late talkers, and we have an entire module dedicated to this, approximately 50 to 70% do show spontaneous resolution by age 3. But the other 30 to 50% go on to have persistent language difficulties that without intervention are associated with reading challenges and academic struggles. Social communication disorders. I'm going to try and pull out a few examples that might give you a better picture of this. If you're familiar with the show Big Bang Theory, think Sheldon. He has a very difficult time with social cues and sarcasm and things like that. Or Sean Murphy from The Good Doctor. These actors do an amazing job demonstrating how difficult it is to understand and use language appropriately in social situations. If you're unfamiliar with those shows, check out some clips on YouTube to give you a better idea of what this looks like. Persistent language disorders can make it difficult for children to understand and express themselves, even into adulthood. This can lead to many difficulties in school, including understanding vocabulary and expressing themselves using vocabulary, reading comprehension difficulties, etc. Although this can seem overwhelming, there are things you can do to help support them at home. There is power in knowledge. Now that we've addressed the language disorders, let's look at speech disorders. Childhood apraxia of speech is a motor speech disorder, not a language disorder, not a cognitive disorder. Children with CAS have difficulty with the motor planning required to produce speech sounds consistently and accurately. What that looks like is highly inconsistent errors, meaning the child may produce a word correctly once and incorrectly the next time. Or they may produce the word incorrectly, but in different ways. I'm going to give you an example of that in just a minute. CAS requires intensive, specific motor learning-based intervention. If your child has CAS, the frequency of therapy matters enormously. So my example for you is the word buttercup. So a child with an articulation disorder might say butterpup, right? But that child's going to say buttercup or butterpup the same way each and every time they say it. A child with apraxia of speech, if I said, say the word buttercup 3 times, they might say butterpup, buttermup, mutterbup. 3 completely different ways. And childhood apraxia of speech it really affects multisyllabic words more than anything. So single words like cat, bat, those types of words probably aren't going to be as noticeable, but with multisyllabic words like elephant or buttercup, those are going to be the ones that are going to be more difficult for this child to say. A phonological disorder involves patterns of sound errors affecting multiple sounds at once. A child might delete all final consonants, not just one, but all of them. This pattern-based errors affect intelligibility broadly. I'm going to say that again. These pattern-based errors affect intelligibility broadly, which means your child might be very difficult to understand, especially if they're deleting a lot of sounds. And lastly, we have an articulation disorder. This involves difficulty with one or more specific sounds, like the R sound. It's a more limited scope. Stuttering is neurodevelopmental, caused by how the speech motor planning system is wired. It has nothing to do with anxiety, nothing to do with parenting, not by anything the child or parent did. We actually have an entire school age module dedicated to this topic. While we're on the subject of speech, I want to talk about the word intelligibility, which you might see that in your report. It's a nice little word that we use as professions that talk about how understandable a child is when they are speaking, or an adult. It could be an adult. But since we're talking about children, it's how well we understand them when they're speaking. I don't want you to think that the word intelligible has anything to do with intelligence. They are 2 totally different things. I oftentimes don't even use that word in my reports because if a parent doesn't understand that is a word that means that's talking about speech, they might get offended thinking that I think their child is not smart or that they're not capable. And that is not true at all. most children with speech disorders are very capable. In fact, super smart sometimes. So I just want to throw that out there as you're reading the report, not to see that word and feel discouraged, because it has nothing to do with intelligence. It's just about how well they are understood when they're speaking. So let's talk about the evaluation report. What do the numbers mean? What are the components of the evaluation? Let me break down the scores section of your report, because this is the part that confuses most parents. And to be honest with you, the SLP usually doesn't have a lot of time to sit and explain all this information in a short session. Standard scores compare your child's performance to a large normative sample of the same age peers. A standard score of 100 is exactly average. Most standard scores are designed so that the average range falls between 85 and 115. A score below 85 is considered below average. A score below 70 is significantly below average and typically indicates a clinical concern. If you'll look at the chart here, you'll see that I have the scores. The green ones are good, the yellow is below average, and the red ones are pretty far below average. And I tend to not want to use the word clinical concern because it just depends on the place where your child is receiving therapy. Typically, if a child is receiving therapy, this isn't across all states, but I'm speaking typically from what I know. If a child is receiving therapy in a clinic, anything below average is below average, and that means they can get intervention for that. Usually insurance will pay for that if it pays for speech therapy at all. Where this clinical concern comes in is usually in the schools. The schools have a much more stringent guideline. They can't just work with children who are below average. They have to be well below average in order to provide those services. And that's based on federal law. Percentile ranks, this part in the middle, tells you how your child performed compared to peers. A percentile rank of 50 means your child performed as well or better than 50% of same-age peers. A rank of 10 means they performed better than only 10%. The scores I want to caution you about are the age equivalent scores. An age equivalent score says something like your child performed like a typical 2-year, 6-month-old. These feel intuitive, but they are not the most reliable score. In fact, they're the least reliable and the most misleading way to report test results. What age equivalent actually means is that for this test to be standardized, the score that your child received, the raw score, not the standard score, which we're not even going to talk about raw scores, but the raw score that your child received on this test is the same as what typically a 4-year-old scored, or a 3-year-old, or a 12-year-old, whatever. That's what age equivalency is. It's like, of the people that they used to standardize this test, most of the kids who scored that score were of this age range. It does not mean that your child is operating at that age range. It's very confusing. I typically, when I'm writing reports, don't even put age equivalency on there because they are not reliable. It's not a reliable way to look at scores. My best advice is when you're looking at scores, look at the standard score and the percentile score. They're far more meaningful. If you only see age equivalent scores on your report, please ask your SLP for the standard scores as well. Now, let me walk you through how a typical evaluation report is organized so you can find what you need. The background section covers developmental history, medical history, family history, and the reason for the referral. Read it carefully. If it misrepresents your child in any way, note that and bring it up. The assessment tools section, or the test used, lists the formal test and the informal assessments used in the evaluation. You do not need to know what all of these are, but you are allowed to ask, were these appropriate for my child's age and language background? The scores section is what we just covered. Keep your focus on the standard scores and the percentile ranks. The summary is your SLP's interpretation of findings. This is the most important section. Read it closely. If it does not match what you actually observe at home, say so in your feedback session. The recommendations section tells you what happens next. These should be specific and actionable. Frequency of therapy, the setting, the focus area, referrals to other providers. If the recommendations feel vague, ask for clarification. And keep your report. Update it when you get new ones. Watching scores change over time is one of the most powerful ways to see your child's progress. I do want to throw one little word of caution in there. Typically, when a child is reevaluated, we try not to use the same test each time, just so that they don't learn the test. But so you may not always be able to compare the same exact test scores together, from one year to the next. You might have to, just kind of guesstimate when you're comparing scores. What the diagnosis predicts. I want to end this module with the conversation I have with almost every family I work with at some point. It is a conversation about what the diagnosis means for the future. And I want to have it with you directly, honestly, and without the kind of false reassurance that ultimately does not help anyone. For most of the diagnoses we have discussed, the research on outcomes is genuinely hopeful, particularly for children who receive early, appropriate intervention with informed and involved parents. Here is what the research is most consistent about when it comes to predicting which children do best. Early identification, intensity, and quality of intervention, and parent involvement. Children whose parents are informed and engaged, like you right now, progress faster, not because the parents are doing therapy, but because they are extending the learning into the child's real life, which is where language actually lives. A diagnosis is a starting point. It is a description of where your child is right now, with the skills they currently have. It is not a ceiling. It is not a verdict. It is a map, and you're holding it. What you know now. Speech and language are different systems. Diagnoses describe where your child is today, not where they will be. Your evaluation report is a tool that works for you, and you are the most important variable in your child's outcomes. As I conclude, I want to bring you into Module 2, where we'll be discussing what speech therapy is. Now, your action plan for this week, I want you to pull out that evaluation report if you have it, find the summary section, and write down one question that you now know to ask, and bring it to your next appointment with your speech pathologist. And I just want to remind you that every child has a voice. We are celebrating the joy of communication together, as we learn, as we grow, and as we partner with the SLPs in our life. I hope that you found this information helpful so far, and I can't wait to see you in the next section.